the clinic to myself. Oh, look at that.
Okay,
we're live. Welcome everybody to this new edition of the Tech Docs Lunch Chat with myself, Dr. Brad Brown, and the esteemed Dr. David Cameron. We both just so happen to be in the greater Denver area. I'm about 20 minutes north of Denver, and about how far south from Denver are you?
About 15 minutes southwest. I'm in Littleton.
We're about, we're, equidistant from downtown. Anyway, welcome everybody. This is, we've started doing this. It's been a lot of fun. It's been well received, so we figure we're going to keep doing it. Today's edition is about after hours and virtual care. How does that fit into the DPC model? This is I don't know about you, Dr. Dave, but this is one that I get asked all the time about people considering switching to DPC, as well as docs who are early on with small panels. How does it grow and how does it change and everything? So I'm interested to hear your views. I know we have some good questions lined up, and a lot of people are going to be asking good questions as well. But little intro, because there probably are some people who don't know us, even though we know each other so well, even though we've never met in person, but we are definitely virtual friends. I have my own clinic here in the North Denver area, Strive Direct Health. I'm sitting here right now, myself and Dr. Schuster. She's not here today, but she sits on the other side of that wall. Direct Primary Care, I've been open a little over 2 years now, steadily growing nice and organically. One of the many hats that I wear, but it's a lot of fun. And Dr. Dave, you're in Littleton.
Yeah, so I'm at a practice called Pure Family Medicine, and I've got two colleagues, Dr. Bubb and Dr. Workman. And so we've been, the practice has been here since 2019. And I also work with Hint Connect with the network, and we're continually increasing the number of docs and the number of employers that are working to try to connect employers to DPC docs.
Nice. I guess I should mention too my connection to Hint. I'm the medical director for the Hint side of things. Small details. Actually, this is a good place to start, if I may, if I can jump right into it. So you've been open since 2019. I opened basically right in the middle of the pandemic, but I want to hear your thoughts on how did your virtual and after hours care change from what was it before the pandemic? How did it change during? And I don't know if we can say after the pandemic now, but how has it evolved since 2020, 2021, right?
Yeah, well, that's a great question, because I've been in DPC since 2012.
Okay.
And interesting enough, I actually, for the first 2 years of my DPC practice, I kept track of all of my after hours and weekends phone calls that people, when they paged me. And it wasn't, this was my biggest fear about joining direct primary care, is like, how hard was it going to be on call 24/7?
Yep. And
on average, it was 2 calls after hours or on weekends. It was 2 calls per week. And then between 11 p.m. and 6 a.m. in those 2 years, I only had 3 phone calls. And so it was really not so bad. Overall, during the week, I had about 30% of my visits virtual.
Okay.
And then when the pandemic hit,
naturally,
pretty much everything went virtual. And then as things have settled down, I think I'm still over 50% virtual. It's hard to say because I do a lot of texting and a lot of quick phone calls and a lot of video visits. And so those are very short. But sometimes when people come in, they may have a 60-minute visit in person. So time-wise, I'm not quite sure how that is, but the number of touch points, I've got many more touch points virtually than I do in person. How about you?
Yeah, that's excellent data. That's why I wanted that question just came to me, right? I didn't think about that one before this, but that's excellent data, because once you've seen one DPC, you've seen one DPC. We say that all the time, but some of the docs that I would talk to are like, oh yeah, I never get a call, don't worry about it. And other ones, a little more on the stress side of like, yeah, I get after hours calls all the time. You don't really know what to believe. What's your demographic going to need? You attract what you are. But at the same time, so that was definitely one of my worries. It still kind of is. But I actually, a follow-up question before I answer, of those 2 per week that you mentioned, how many are those 2 that you felt like you had to respond to? Because I get after hours text all the time. Hey, can I get a metformin refill at 9 p.m.? It's like, well,
Yeah.
I don't count that as a after hours text, right? Are you saying 2 that you needed to respond to?
In the first couple of years, there were more of the unnecessary page. We had a system then that was kind of like a paging system.
Gotcha.
There were, I would say, I don't know how many, but maybe 25% of them were unnecessary,
Sure.
that they were things that could have waited till the morning. And
Yeah.
so over time, as I educated my patients and trained them what needed to be dealt with after hours versus what could be sent by way of the routine messaging from 8 to 5. Most patients, once they realize how easy it is to get access, they would stop paging after hours.
Yeah. Yeah.
Um,
Yeah, exactly. And actually, when I opened a fellow DPC doc here in Denver, I cold called her, Brianna Seafelt. I don't know if you know her, my Denver DO, but I picked her brain a couple different times, and she said, "Hey, start early in that training process, right? Because when you're just starting out, you're in the growth phase. You want to offer above and beyond. You want to get those good reviews." And if you're switching from the system, you feel like you have so much time that you can go above and beyond, right? And then she said, hey, make sure that you do it the right way from the beginning, because what she did, her advice was, I did that for my first 100, 200, 300 patients, and then they still expected that when I had 5, 6, 7, 800 patients, and I couldn't offer that same level of care.
Yeah.
I thought that was fantastic advice that I have not heeded, if I can say that, right? I've still done it exactly how she did it beforehand. But for me personally, I mean, we opened March of 2021, and again, there's been a lot of virtual, there's been a lot of touch points, but my training for my patients, I tell them, hey, I will not respond to things like medication refills. Just know that I will during the business hours, right? I'm not going to say, hey, I'll get to it in the morning. I'm just not even going to, I'll see it, but I'm not even going to respond to it, because that's my value add for patients of, hey, when you're thinking of it, send me the message. If that's at 2 a.m. and you're thinking that, hey, I need my blood pressure meds refilled, send me the message, right? Because you probably won't remember when you're in the morning routine, getting kids to school, going to work, So I'm okay with them sending it to me. I just tell them I'm not going to respond until.
So does that message wake you up?
No.
So how do they differentiate between something that needs to be addressed urgently versus non-urgently?
That's the next step of it. I tell them all, if it's something after hours that is urgent, call me. And if I don't pick up, leave a voicemail or call me right back again. Because if I get 2 calls from my clinic number at the same time, then I know it's something urgent. There's services out there that you can do a phone tree, there's different triage and things like that. But the way the all-in-one system is set up, is that's not the point of this call, but you can definitely figure it out that way. If it's something that can, wait till business hours, shoot me a text. And then I also have an auto response to where it says, hey, thanks for reaching out to Dr. B and Dr. S, after hours. If this is urgent, reply urgent, and then it'll get through and ding even louder, or give us a call. If not, we'll respond in the next business hour or 2, right? So there's different ways, there's different services, different technology you can leverage to get some sleep.
Yeah, that's important.
And also I have a luxury of having a second doc, right? So I can sign off. You have a couple of docs to where you're not on 24/7. You're on 24/7 for 1 week, and then you have a couple weeks off of the phone, right? So that's obviously a luxury that clinics starting out, a lot of them don't have. So that's again, once you've seen one, you've seen one. So anyway, I think I beat that one to death.
Well, in our group, we've been on Spruce and Elation since 2019, and I just was up skiing. I was up at Steamboat for the long weekend, and so I love it because I could totally sign out, and all of my I didn't have any calls over the weekend, but all of my kind of non-urgent messages got routed to my colleagues, and so that way it gives us some ability to be able to unplug. I think that's important, to be able to unplug, especially when you're doing 24/7 as a DPC, a great DPC doc and a great practice. It's nice to be able to be able to have an opportunity to not have to respond to those messages and those demands, but even if it's like a refill.
Yep, absolutely. and our spouses would agree that putting our phones down is a win. I know my wife is probably watching and she's just shaking her head like, "You're always on the phone." Yeah, I know, but I can do
Hey, tell me what's your patient experience like? What do your patients say about the virtual care experience?
From what I've heard, and maybe I'm a little biased, they love it. I pitch it kind of as a convenience, right? To where, again, if you have that thought, just text it to me and I'll get back to you as soon as I can, right? If it's urgent, give me a call. But the demographic that we're in is maybe skews a little bit younger, a little bit healthier, but they have young families. So they love to be able to text, "Hey, here's a picture of my kid's rash," or, "Hey, my husband doesn't ever want to see a doctor, but here's, he's having this complaint," or something like that. So they find the convenience is extremely valuable to them.
Mm-hmm.
And between the two of us, we can respond in a very reasonable manner. And so that's kind of how we've structured the virtual touch point, if you will, to where it can be mainly a convenience thing. There's a better word I can't think of right now, but convenience mainly. How about you?
I was just thinking, because as patients get to understand how our practice operates, it totally flips the communication and how people touch base with me. Like when I was in fee for service before, and the way that people would this was before most practices were having ways that they could do chat. So most people would call, they'd schedule an appointment, it would get booked out a couple of weeks, and then they would come in and we'd have an in-person visit. And that was the typical flow. And in my current practice, most people start off by messaging. They send a secure text, and if we can manage through text, then it's done. Then we may need to escalate up to a phone call or a video visit. And then probably 30 or 40% of the time, it may need to be an in-person visit. So it seems like the process where it was primarily in person is flipped on its head, whereas the in person is either for a physical or an annual visit, or for something that needed to get escalated up to the point where they actually needed to be seen in person.
Nice. Yeah, that's excellent, and that works for your demographic, and that's the key part. We have a great question from Beth Holmes. How can DPCs who don't practice in a group setting unplug? This is the one, I'm sure you've heard it as well for clinics that are starting up. I like this one because the DPC is such a close-knit community. It's growing rapidly, but everyone is so supportive and so helpful that in your given city or town or location, then there's usually groups of DPC docs who help cover for the odd times that you're completely off the grid, right? Some docs, they'll send out a mass email that say, "Hey, this is a time where I'm going to be at Steamboat. I'm skiing, so please get your med refills in early. If it's anything urgent, I'm going to have my other colleague cover, or not. Just go to urgent care," type of thing. There's a few different ways to do it, and it's pretty flexible. At least that's in my experience. Because there are a couple times when myself and Sarah are both gone. She's a big backpacker with her husband, so they literally go off the grid. And then, if there's a time when I'm out with kids or on a trip or something, but yeah, I don't know. How have you done?
How does that work with Hint All-in-One? If there are two different practices, can they be able to visualize and see chart notes from a different practice if they're covering?
That's a good question. So yeah, you just created a new user. So let's say you're covering my practice. I would just create a user in my Hint All-in-One for you, and you have your own unique login. You have your own prescribing rights and everything. And then you can see, I can set you as a different security level, if you will. But as a physician who's covering, I'd set you to where you can have all the access that you need. So you could see if someone texts, "Hey, I have a headache," you can look at their notes if they had a previous headache or something like that. Or, you'd have the ability to at least triage and say, "Hey, this is," and if you need to call in a med, you can send it over through that system as well. So then it's all logged in the chart. So then when I'm back, then I can see everything that's done. It's pretty seamless.
Yeah. So with ours is a little bit similar. It wasn't quite as savvy as yours, but I covered for someone when they were on spring break, and he's not part of our practice. And so I was able to access his through a different login, but I wasn't able to do video visits. I could do phone visits. And obviously he was too far away. Like not obviously, but he was too far away to do in-person visits.
Yeah.
And so I would just cover with phone, but not video.
Yeah.
But I was able to get the records to be able to review them. And I could also send in prescriptions through his instance of the EMR.
Yeah. Which in a pinch works, you know, I mean, just in case someone needs something, but
yeah. Hey, how many of your patients are kind of out of state or far away or primarily use virtual care?
You know, we actually have patients all the way from Fort Collins all the way to Durango, which in Colorado, that's like a 7-hour spread, 8-hour spread, for those who are not familiar with the state. But as long as we see them once a year for their annual physical and they have an address in Colorado, then we're okay with that. A lot of them use us virtually. And then if there's anything acutely, they go to urgent care, or if there's a DPC in the area, I'll call that DPC real quick and be like, hey, one of my patients is in your area. Do you mind if they swing by today or tomorrow for a quick visit, check their ears or something like that? And then I'll DoorDash that DPC lunch or something like that. I don't know. Yeah. You know, a couple exchange or, you know, students studying abroad, they'll you know, in Paris for 6 months or something, they'll shoot me a text with any questions like that. We do a lot of virtual stuff, video calls, you know, I don't know how it is for you, but the men who sign up, they're like, oh, I never go to the doctor. I'm never going to use you. They're like our highest utilizers because they, you know, it's like so convenient just to text us. Yeah. But, you know, they're away on business trips and they're like, hey, you know, I ate something funny here. Can I chat real quick? Like, totally easy. So traveling within the state licensure laws, right, is, I think the DPC in general is basically built for that, right? Yeah. How do you do it?
Well, you know, I have got quite a few patients that are snowbirds or they travel. I actually had one person that a few weeks ago, he was in Mexico and he got sick and so he needed some medications, but he wasn't sure which medicines to get. And there he was able just to go to the pharmacy and ask for whatever he wanted, but needed some help with trying to figure out which medicine was which, because the names weren't the exact same medicines. And so we were able to navigate that. I got quite a few college students that go out of state. And I do have quite a few medical licenses being a part of the network. Nice. And so I have some ability to do some out of state care, but you can still manage patients that are traveling and send the prescriptions in under current regulations. And so I think it works pretty well. I think a lot of people like it. And I find most of the time urgent care issues, and maybe we can dive into capabilities and limitations, because I used to think that patients needed to come in person for more than I think now. My position has changed over time, and I think the capabilities have changed. And so let's just raise this topic, like what can we do virtually and what do you have to do in person?
Yeah, that's a great point. And I was about to say something that could be a little offensive. That comes with experience. I'm not saying you're old, but you have a couple more years of experience in the medical field than me. And I actually was at a networking thing for the local chamber this morning, and someone gave a presentation on confidence, right? And confidence is, you're not born with it. You're actually, it's developed with practice and repetition. And so, based on what another human tells you, if it's the level of severity, right? I mean, hey, this is outside the scope of my practice. Even if I was sitting in my office right now, I would still send you the ER, right? Versus, hey, I'm at the top of the mountain on Steamboat. I could probably triage this from the lift, and this and take care of you, texts and a quick phone call. So, I mean, that definitely comes with, I think, the stance on that shifts the more patient hours, the more interactions you have with people, and as if it's a new patient you've seen one time a year ago, that also changes things, right? I mean, if it's someone you've been seeing for 10 years, you can trust them. Mama bear knows what an ear infection is for their 6-year-old or something. So I think it definitely, in my view, it's definitely nuanced. But that's the beauty of DPC, right? Is to where the patient's not calling a call center line, and then half the calls that get through to you are kind of pointless anyway, because you have total control over what is done. And so my type A personality loves that control.
Yeah. And no offense on you telling me that I'm really old and over the hill. No worries about that.
I'm like a day older than what, 18?
I had a patient, she goes, you know what? The best investment I've ever done with my 5 kids is I bought a $39 otoscope with a camera on it. And she sends me pictures of her kids' ears.
I have one right here. I use every day, and I tell parents to buy this. It's $18 on Amazon.
Okay, $18. She's only at 39.
Yeah, I'm not going to tell you the brand because that's not the point of this call, but you can get these things on Amazon. Yeah.
Now, is that the one is that the earwax removal, or is that
has those
for
capabilities as well.
The picture?
Yeah, it has a camera and removal. It's fantastic.
Oh, it's great. You know, I found it. There's a whole bunch of things like sinusitis. I've really started to wonder how much more information do I get for seeing the person in person, seeing a patient in person, versus virtual. And I don't really find the in-person adds much. Sometimes if someone could give me their vital signs, they can check their temperature, and they can tell me if it hurts. I'm rarely going to get a CT for someone. But I think there's a whole bunch of things like upper respiratory infections, oftentimes a lot of musculoskeletal dermatology, mental health, gastroenteritis. There's lots of urgent care issues that I think are amenable to virtual care visits.
And here's a question for you. How ballpark this in the last 24 months, how many times have you avoided, maybe 12 months, pick a time frame, have you helped avoid an unnecessary urgent care or ER visit? Where if someone was like, hey, I was going to go to the ER anyway, but you helped me over the phone or even in person.
Yeah. Well, I don't always know how many of my patients go to urgent care or the emergency room.
Yeah.
Because sometimes you just don't ever find out about that information. Yeah. But I also think there's plenty of times where I'm taking care of a patient and I know that they would have gone to the urgent care emergency room if they didn't have that visit. And I think this is a value prop for direct primary care. Yeah. I think when, an average ER visit is $4,000 to $5,000. And particularly if you're with a self-funded employer where the employer is going to be paying for that emergency room visit, if you save a single ER visit by taking an after-hours phone call, that's several years worth of membership paid for right there. Yeah. And so I think that happens routinely. I think on average, probably 9 times out of 10, I can manage the patient virtually. And by one time out of 10, I'm like, I don't feel comfortable. That right lower quadrant abdominal pain, I think you should probably get that checked out in person. So I did used to work with an organization where we would get claims data. And so we could actually see all of the claims that were going to the TPA, and then we would be able to review them. And when we would compare diversion, we call it diversion rates. There was probably a 40% diversion rate because of after-hours phone calls. Now I don't want to hang my hat on that, but I think it's probably in the right ballpark.
Yeah, and at scale, I mean, with three docs, 40% of your whole panel of touch points. I mean, that's a pretty good utilization. So yeah. Beth has another good question, actually. 2-part question. Do you ever have patients who want to come in but think they should be seen virtually, or vice versa? How do you handle that?
Do you ever have patients who want to come in but frankly, my opinion is I'm a consultant for patients. Nice. And if somebody wants to be seen in person, I'll see them in person. If they want to be seen virtually, I'll see them virtually. I think the biggest issue, if they want to be seen virtually and I need to examine and do a special, if I need to do a McMurray's or a Lockman's knee test on them, or if I need to give them a vaccination, or if I need to do a procedure on them, then I need to convince them to come in. I don't know. What do you think?
Yeah, I would say it's definitely more often that someone's like, oh, this is a virtual, I don't want to come in, work, school, kids, whatever. Can we just do this virtually? And you're like, your spidey senses are saying, I need to like push on your abdomen, I want to make sure, or something like that. Very rarely am I trying to pitch someone like, hey, you don't need to come in, because I'm in the same boat. Like, yeah, do you want to come in? Absolutely. It's a touch point. It's face to face. It's, relationship building. I might push it off a day just because, some things don't need to be seen 5 minutes after you text me about it. But yeah, I'm in the same boat. It's how do I handle it? It's all discussion with the patient. It's all triaging it virtually, text, phone calls, even jump on a quick, video call, and kind of go from there. But it's a good question.
I think more people want virtual, and they're reluctant to come in. I think that's more of the issue rather than the opposite.
Yeah.
And then I sometimes have to have the discussion like, okay, there are limitations with virtual care.
Yeah.
And what for you, what are some of the biggest limitations you find with virtual care?
I find expectations, actually. I feel like if that can be an answer to your question, I think it's, some people expect me to be able to just make a diagnosis based on the 2 words they sent me, and then they don't text back for 3 or 4 hours. And you're like, and then it's like, hey, did you call in that antibiotic? It's like, well, first of all, you don't need an antibiotic because you twisted your knee, but whatever. So I think it's managing the patient's expectations of what you can and can't do virtually. Like we were just talking about, but getting them to understand like, hey, we can do a lot, especially in this day and age. We can do a lot virtually, but there are some things that you have to see in person. It's mainly expectation managing for me. So,
yeah. So you're not doing procedures virtually. You're not doing the Da Vinci robot.
it's just slightly outside my budget, but hopefully in 2024 I can get one of those in every household, right? So
yeah, I think you should work on that with Hint All-in-One.
That would be something else.
I've had a couple employers that have Tytocare. I don't know if you've used much Tytocare, but they've got an otoscope, stethoscope, and it just plugs into the laptop. And it's mainly the employer that has a room that's got this set up so that their employee can come down to the room. Yeah. And then it helps for auscultation, for taking a look in the ears to get a good set of vital signs.
Yeah.
I thought it worked pretty well. One employer that was fairly remote had this, and so they could be able to have their employees be able to get care, and then be able to go right back to work instead of having to travel a long distance to be seen. So I thought that was pretty neat.
And
some people use their wearables and send information through their wearables.
There's actually, if we're talking, there's a really cool, this is not a plug, maybe a little bit of a shout out. Human OS is a really cool company that I've just been, I signed up for myself because I was curious, because I want to see if it's value for my patients. But it's this dashboard that, it links with all your wearables, your Garmin, your everything like that. And then it has all these recipes and food planning and workouts and everything. And it's all tracks everything, all of your objective data on a dashboard. And I think it's really cool from a consumer standpoint, because I'm a data guy. I love all that stuff, right? I think in Excel sheets. And so having all of that in front of me, I think that'd be pretty cool for a doctor to sign on virtually, hey, I'm trying to lose weight. Here's all of my stats. I can sign on, or here's a screenshot of everything. Like, here's some tweaks here and there. We have quite a few engineers in our practice, and they love sending me these giant spreadsheets.
I've got a few of those too.
Oh, I took 3 less steps today than I did yesterday. What do you think? I'm like, well, I think you'll be okay. But the engineers love to, do that, and I love it too. But go ahead.
I was just going to ask you, how are you implementing or including virtual care with chronic disease management?
Yeah, that's
other than accepting all these massive spreadsheets about your patient's blood sugars.
I know, right? 5 minutes ago, the blood sugar was this. No, that's a great question, and I think that goes back to experience of what you're comfortable with, how well you know the patient. If you've been managing this, high blood pressure for 10 years, or is it you just met this person the other day? I think at least getting a routine face to face. It can be in person or a video call is very important, because my personal style is, I'm one spoke of their healthcare team wheel. They're the hub. I'm one spoke. And so being able to work with them face-to-face in person, and then maybe every other visit or every third visit is in person, but then do more virtual in between, just as, for convenience. I think there's definitely value in that, but also it allows me to be the accountability person to them, right? Hey, you should take 3 more steps tomorrow than you did today, or something like that. I don't know. How do you do it?
Well, I was just thinking about the problem of non-adherence in the United States. I mean, there's studies that show, greater than 50% of prescriptions are not either filled or not taken appropriately. And as a result, we get a lot of patients with CHF that end up in the emergency room because of volume overload. And I've found that having a quick follow-up message or quick phone call or video visit, like after starting patients on a new medicine, is really helpful. Because then I know right off the bat, like, okay, did you have a side effect to the medication? I did this with a person who's got asthma. We started them on a controller med. And then just after a week, just did a quick touch base and say, hey, how often are you using your albuterol now? And I found that was really helpful.
Nice.
I find so I think I've been getting in the practice now of when I start a new chronic medicine, about having a touch point in about a week or two, just to make sure that they're not having a problem, to make sure, is it working? Is it helpful?
Are they taking it?
And are they taking it? Yeah. Or, do they have a problem with the PA? Is there a prior authorization issue or something like that needs to go? And I found that we've had to troubleshoot quite a few times. Now, I don't know the data if this is helping my adherence. I like to think it is.
Sounds like it is.
But I think that can be particularly helpful for chronic disease management. And I don't think you need to have somebody come in just to have that. And I think a quick text, a secure text, can be really helpful for that.
Yeah, I like that. That's really good. You should teach many other DPC docs like myself that's a fantastic thing to do.
Yeah. And another thing is after procedures, oftentimes I just send a quick message after about a week or so and just say, hey, how are things going? Did that steroid injection help? Or how are the whatever procedure was done, or if they've had a surgery to check in that way, that can be helpful.
And from a business standpoint, that really solidifies that connection you have with that consumer, right? I mean, they really appreciate that. And then all of a sudden they're top of mind again, and they're telling their friends about it too. So again, not the point of this live stream, but there's multiple reasons to do that.
Yeah, and I think it was like 83% of all healthcare spend is due to chronic disease management and the complications. And so if we can do what we can to make sure the chronic disease states are well managed, and if patients are adhering to their medications and their regimen, I think that not only is good healthcare, but it can help really bend the cost curve.
Yeah, that's fantastic. A little data behind it. So you are, we'll say, for the lack of a term, a network guy, right? As the CMO of HintConnect. So Taylor, this question to you: how about virtual care, for the lack of a better term, across a network? Maybe not HintConnect specifically, maybe HintConnect specifically, but how about an employer with 10,000 humans across multiple states, and there's a network? How can virtual care play a role in that? You already mentioned it with your remote employer that had the room set up, but maybe a broader context.
Yeah, well, it's challenging because you get an employer that's across multiple states and in large geography, and there's not DPC locations everywhere, particularly in rural areas. And so then the question is how can you give this experience? Because employers want to have this benefit. They want this DPC benefit to be for all of their employees and all of their dependents, so everybody on the benefit plan, so that it can be equitable. And so it's a challenge to offer in-person DPC because we could try and encourage doctors to move to certain locations, and that may or may not be successful. One thing that we've decided to do is to partner with a virtual direct primary care organization called Eden, and they've actually got primary care and specialty care, and so it is a nice complement to the direct primary care network. So if there are patients that it's a long drive to go to a DPC, then they've got a virtual direct primary care that is a continuity provider for them. And so I think that's helpful. I also think, for self-insured employers, if we're going to be able to tap into a direct primary care, we want to capture as many patients as possible, because the higher engagement there is, the more they're going to have healthy employees. It's going to decrease their absenteeism, and also it helps to decrease their healthcare spend. And so I think whatever we can potentially do to offer either in-person DPC or virtual direct primary care benefit, I think it will help the customer satisfaction, the quality of care, and the cost, the triple aim for those employers.
Nice. I like that. Yeah. I can't really speak to, networks that as well as you can, so we'll leave it at that for that one. I think from the doc standpoint, someone who's not running a network like you are, my thought is, okay, I go work at the ER on the Eastern Plains of Colorado, only doc within 50 miles type of thing, farm towns. But it's an ER inpatient setting. I cover a little bit of the clinic. But at the same time, it would be great when, if there's, let's say, there's 3 or 4 employees of a large company that work in an area like that, to where, they have a DPC benefit, they could just call me in my clinic. We do as much as we can virtually. It's at least, may not be perfect world, because there's not a DPC right down the road from them, but it's definitely something, right? And so I would be more than happy, as on this side of the network, right, to say, hey, I'm a doctor. I'm here to help people, right? That's the whole reason I went into it. Do no harm. So if anyone who is in a rural area needed some type of care, I'm happy to help to jump on virtually. And I'm pretty sure, I'm not going to speak for the general DPC community, but I'm pretty sure everyone would say that, but we'll say 99%, because we can't say that, but no, I think that's excellent. So.
Yeah, I know our time is coming rapidly to an end, but I wanted to ask you, how do you envision the future? What do you think is going to happen in the next 5 to 10 years in terms of virtual healthcare?
I mean, it's kind of in a little bit of an upheaval right now, right? There was a big shift during the pandemic, naturally, during the height of the pandemic, shall I say. And now, there's some rumblings of, some legislation changing, shifts to shore some things up for reimbursement in the fee-for-service world. So it's definitely a pendulum, and I think it's a 3-dimensional pendulum. It kind of swings in different ways, but with the technology that is at our fingertips and the amount of information that's at the fingertips of patients, I think the convenience of virtual care is what is going to drive this thing. And as patients see the value in, hey, I can just text my doctor. I don't have to sign on to an app to get some doc I don't know. I can text my doctor. What do you think about this latest worldwide pandemic, like that?
Yeah.
I think it's gonna really continue to take off. It might not hockey stick, but it'll be a nice, steady, big change in the DPC space. There's a groundswell. I was listening to Clint Flanagan of Nextera Healthcare here in Colorado. I was listening to him speak a couple weeks ago. I listened to him all day, but he said, there's this groundswell. I love that word, of consumers, of businesses and patients, and the connection between the two, to where that's going to drive this going forward. And I'm sure you've seen it with Hint Connect, that there is a need for it. And now we just have to make the connections to where it can actually happen. So long answer for your question, but
well, I was just thinking, because a lot of people are saying, like, gosh, I don't want to do my physical exam, or I don't want to do my well child check, and I know, like, with pap smears, first off, we're not doing them nearly as often because of the HPV vaccine and doing HPV and co-testing, all that stuff. But this whole whole issue, or whole kind of new technology of home cervical cancer screening, and I know a lot of other countries are starting to adopt it. I know Everlywell and testing.com, a lot of patients are starting to do it on their own, but it's not FDA approved. I think it's CLIA-waived, but not FDA approved at this point. But I think at some point it's probably going to become more mainstream, so that certain types of testing can be done. You can do some things, and you can order more tests where the patients don't have to come in for that specific procedure. And I think my wife would be really happy about that.
Absolutely. But no, I mean, that's exactly it. There's always things you have to see with your own eyes, palpate with your own hands. But at the same time, it's definitely shifting. So
yeah.
Any last comments, concerns?
Well, I was going to ask you,
Okay.
What are your thoughts about like ultrasounds that are starting to, plug into compute? Like, I don't know if you've kind of been keeping up like with Butterfly and other types of technologies and I know that some employers and some institutions are starting to purchase these because they're not too expensive. And that the patient is plopping it on themselves, and then the doctors are starting to diagnose it virtually. I would never feel comfortable. I don't, at least right now, I would not feel comfortable doing that. But do you think there's any future in that?
I mean, sure, in the future, whether that's a year or 50 years, who knows? I think, because like point of care, we do it all the time. I'm not a trained technician. I have some training. I use bedside OM in the ER all the time, right? But sure, I can see gallstones, but I always get a formal scan, and I always get a formal radiology read, just because I'm not trained. I'm not, a licensed technician, right? I can see it. I know what it probably is. My clinical intuition says one thing, but again, that's my hand doing it. If it's a patient putting it on themselves, again, I don't know if I'd feel 100% comfortable with that. But.
Yeah, no, I'm just kind of wondering what's going to happen in 5 to 10 years. And I think there may be some new technology where patients are going to be having different types of wearables that will give us more information and help us out.
A wearable ultrasound, just Tony Stark style. I like it. Yeah.
Well, this has been fun. Any last parting comments? I think we've covered quite a lot of information.
Yeah, this is great. No, I'm good. This was fun. Thanks for everyone for tuning in. We're going to do this again next month, I guess. We'll feel free to shoot us any comments on any topics you want to hear. But if not, we'll keep having this fun banter, right? Going back and forth. But,
hey, sounds good. Thanks so much for the conversation.
Absolutely. We'll see you next time.
Have a great day. Bye-bye.